Welcome to the Real Integrative Medicine podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in. Okay, guys, welcome to this episode. I am so excited for this conversation that we are about to have. I think in this moment, we might have one of the most, or maybe she is the most famous urologist on earth right now in the room with me. Welcome, Kelly Casperson,
the most
to
blushing
Real
one.
Integrative Medicine.
Thank you for having me.
I'm so proud of you, which is funny because we don't know each other, but I'm so proud of the impact that you are having on women's health right now online.
Thank you.
What I've watched from you over the last couple of years has turned me from like, who is this person with the amazing hair, to this, like, you're an absolute force talking about menopause care, the inequity in menopause care for all people, and the impact of the lack of research on this area as it translates into women's healthcare. Thank you so much for spending this time with us here today. I have a lot for us to talk about.
Thanks for having me.
I would love if you could start by just giving our listeners who are new to you, which they won't be after this, but that are new to you, a quick synopsis on how you got to this spot in your career. It's not a typical path to go from urology to menopause advocate, in my experience. I'd love to hear how you got to this spot.
Yeah, it's good to point because people are like, so I just need to find a urologist. And I'm like, that's not going to work. We can't lead with that because they're like, I'll just find a urologist. I'm like, no. So I was about 7 years into my career, general urology, but focusing on female pelvic disorders, prolapse, incontinence, and had basically a life-changing patient come into my office, and she was dealing with some sexual health concerns in her relationship. And I was very bonded, and I'm quite aware, had I not been bonded to this person, I would have been like, sorry, like, can't help you. But instead it was like, how is it possible I don't know how to help her? How do I deal in Viagra and penises and erections and male pleasure being such a default? It is malpractice for us to discuss any sort of surgery or medications on a male that might affect sexual health and not discuss that. That's malpractice. And who's taking care of the women? Like, maybe the gynecologists are. And so I started really deep diving into sexual health and realizing there's actually tons on female sexuality that people just don't know because we didn't get a sex ed. Doctors don't know about it. Hollywood tells us everything wrong. We live in a heterosexual relationship. We live in a society that prioritizes somebody's pleasure over another person's. And so my interest in female sexual health, and that's what I originally started my podcast called You Are Not Broken, was to educate female sexuality. Like, that was the niche. And it kept coming back like, well, you know what happens with menopause? Well, you know what happens with menopause? And it was like, it was the repeat question enough. I'm like, what the hell happens with menopause with your sex life? Like, and it was the same sort of curiosity. So like, curiosity really has driven all of this of like, well, what happens with menopause? Okay. So no, sex doesn't always go bad after menopause. What's the role of hormones? Okay. Oh, okay. So estrogen makes people live longer. That's fascinating. How come everybody's afraid of it? Okay. What's the WHI? Okay, well, I give 10 times the dose of testosterone to the dudes all the time. They seem to be fine. And so it was just like this peeling back the layers and using curiosity and using the lens of gender equality. And I think that's what really sets me apart compared to the gynecologists, is they don't take care of the dudes. Primary care doctors do. Lots of people take care of men, but like, the gynecologists don't take care of men. So they do not understand that when a man comes in with low libido and low testosterone, we don't tell him to drink a glass of wine and find an acupuncturist. Like, they're legitimate medical concerns with legitimate safe treatments, and we offer that to them and we care. And so to me, I'm always like, listen, I'll stop working when this is all equal. When we treat everybody the same in medicine, my job will be done. And I'd like to say that would be happening soon, but we've got a very long way to go. Like, something like, to me, like, my passion is testosterone because I'm so comfortable with it, right? And it's like there's so many barriers to testosterone that it's like sometimes it's just overwhelming. Just getting the boxed label off of vaginal estrogen is like a freaking like multi-year project. So with things that are like so obvious once you have the knowledge of, like, it's insane to put on a skincare product that it causes dementia. Like, it's insanely wrong. Like, vaginal estrogens just got wrong labeling on it. So that's where I came from. Started out with sex, ended up into hormones, and used curiosity and equality to like drive the bus.
I love that story. And I've said on this podcast, talking specifically about mood and hormones, that is this other area where it sort of falls between the cracks of two specialties, right? Where is it like the psychiatrist's job to be like, well, how does this relate to your menstrual cycle? And did you have postpartum depression? Or is it the, menopause gynecologist's job to say, do you have depression? Do you have anxiety? That's this other area where there is this intersection between where it's like kind of nobody's job to ask about it. And it falls between two lines when it comes to treatments as well, right? We'll have the psychiatrist use very different solutions. They're maybe not going to look at HRT at all. And then your gynecologist is going to look at very different things and maybe not ask about your mood at all. Is the same thing happening here when it comes to sexual health for women, where it like doesn't really fall in anybody's camp as far as subspecialty?
Yeah. I mean, I would argue this is, first of all, everybody's job, certainly primary care. Like, the easiest access is, this is 50% of bodies, and 100% of these bodies will have hormone changes if they live long enough. Like, those like basic numbers, you can't have a subspecialist manage 50% of people. Like in America, we have 28,000 gynecologists and we have 80 million women over the age of 40. Like, the math doesn't math. And I think one of the great injustices to women in medicine is the false belief that one group of doctors is supposed to take care of all the female problems. Like, that's insanely unfair. And, truth be told, gynecologists are taking care of life and death situations. In the triage of like stuff that has to get done today, perimenopausal hormones is not at the top of the list. And they also didn't get taught about sexual health. And plus, they've got a big gun called birth control pills, right? And so they tend to gravitate towards that, even if you don't have sperm in your life or a birth to protect from. So I think it's a big gender bias injustice of like 50% of the population can only go to that group of doctors for all of their female issues. It's bullshit, frankly.
Yeah, and it's interesting. Like, I would say probably the Canadian experience reflects that, where we are one of the only developed nations where you can't directly book with a gynecologist. So we have this whole other challenge where you have to be referred by your primary care practitioner. And with so many people in Canada not having primary care, they're going to a walk-in clinic saying, can I get a referral to a gynecologist? So we're one of the only nations where there is the gatekeeping of the gynecologists. But then even once you get there, what their focus is, like you said, is these much more triaged areas of medicine or much more surgical areas of medicine. We also, in terms of like the way physicians are compensated, they maybe get 50 or 90 bucks for doing a 50-minute menopause exam.
Mm-hmm.
I mean, I would argue that even 50 minutes isn't long enough to help someone's menopause. And yet, the structure of it is really not supportive of the doctors choosing for that to be part of their practice. So interesting, because like even just those like systems things, often women, I think, will feel like it's their fault that they didn't take action or they didn't get what they needed. But there is this like systems effect of the way that we've set up medicine that makes this so difficult for them to access.
Yeah, it's a total systems problem. I was paying a bill for headshots for somebody that I work with, like, a nice photograph, headshot, $500 for a half an hour of their time. Okay, how long did it take me to get good at my job? About 2 decades. right? And I'm life and death, and I've got my license on the line if a bad thing happens that I didn't educate you about. Like, the stakes are so high, it takes so long, and then they're paid absolute shit for doing it. Like, it's a joke to think that this is sustainable. And I think we're at the point now where I'm not that radical to be like, it's not sustainable. The amount of people leaving medicine at this point, like, I could go be a professional photographer. I get $500 for a half. Granted, she's highly skilled. She's worth it. But I'm highly skilled too. And so are you, right? And like, we've decoupled how incredibly complex this job is to take care of somebody else's hormones and be in charge of the medications that go in their body, and then reimburse them so poorly that they're not going to actually do that job. And then you're like, there's nobody to take care of us. And you're like, well, no shit. You set up the system that way. The other interesting thing about British Columbia that I learned doing another podcast is, I'm always like, get a second opinion. If you go for hormones and they don't offer hormones or blah, 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 I'm like, get a second opinion, which is already a barrier that like women have to get second opinions and men don't. And then they were like, well, you can't get second opinions in British Columbia. You're basically stuck with the doctor that you're assigned to. So the health of you is dependent upon what one dude knows. Like, that's frightening.
Yeah, it's frightening. It takes that like consumer option away, right? And it's funny because, and now that you're saying that out loud, like so much of what we talk about on the podcast, and one of the things I have in my list is like, how do people advocate for the care they need? And it's like, it's because there is that lack of like choice, right? So they are stuck with the person that they're sitting down with. That is their best shot of getting support. And so we talk about equipping people with the right questions, the right language, the right information so that they can advocate for themselves. And I'm like, as you're saying that, I'm realizing just how disappointing the fact that we even need to have that conversation is.
Well, and we're assuming like, I'm feeling pretty good sitting here podcasting with you. My energy is good. I exercised today. Like, I'm pretty good at advocating right now because I'm relaxed and I'm healthy. Right. So take a power differential in a strange clinic situation with somebody who's actually feeling crappy, and you're telling them to advocate. Like, that's way harder.
Way harder. And
I can't advocate when I'm sick, like, because you're sick.
The generation, and I hope, and this is one of my questions for you, is like, where do you see the shift in the narrative? But, go back 20 years, like my grandma was like, no, the doctor said this, like, that's their right? There is no other option. Their word is the word of law. And I'm hopeful that narrative is shifting a little bit. But what have you noticed? I feel like you get this amazing bird's eye view. You have such a big audience who feeds you like the real-time experience of what it's like for people to try and access hormone therapy, testosterone therapy right now. What is the current culture, and where do we have to go from here essentially?
Yeah. I mean, the current culture is the educated people with resources are getting care because they've got some time, they've got some money, they've got, friends who are doing it. So like, who are you seeing? A lot of the resources like that. And that's the way, in all fairness, that's, short skirts that showed your ankles happened amongst the wealthy first in the 1800s, right? Like, the people with access tend to bring the trends, and that's who you're seeing start the hormones and the longevity. And so in 10 years, what that means is people who've started hormones today are going to be vastly healthier than the people who didn't have access. So the health disparities is going to increase. And we have that data. We have a published data looking at Medicare, which is our healthcare system for older people. 65-year-olds who've been on hormones for 10 to 15 years, by and large, in like 10 different metrics, are healthier than their counterparts who aren't on hormones. So like, we already have the data, but I think it's going to get more pronounced as we're seeing more people advocate and people not have access. So I think that's number one, is there's a healthcare disparity based upon who can access. Number two, what do we do with ChatGPT and all the, data processing of like, doctors might not have to go to school to memorize stuff anymore. And doctors might not have to go to school to like continue to stay updated. I didn't learn most of this in med school, but it was my insane curiosity that has given me this knowledge, right? So what do you do when like ChatGPT can tell you the benefits of estrogen if there's correct data on the internet, right? That's a big problem with the WHI. But I think what the doctor-patient relationship, to have a guide, to have somebody help you interpret things, that's invaluable. And I would say becoming more valuable but only for people who can access that, right? But like people want a relationship. Like I want to like my accountant. I want to like, I trust and like the place I take my car, and so it's like the role of the physician is going to change because all the knowledge is now in a computer and it's being updated. But so the doctor is going to have to help you navigate that and be like, you have a million choices now. Let me help you navigate that because I'm in this world a lot. And like, you have Instagram. There's so much crap on there. Let me tell you what's actually validated and what's not. So the doctor as a guide and a leader to your healthcare, instead of I said so because of something I learned 20 years ago, that's how it is. Take it or leave it. Like that's old school. And I would say not great care.
It's interesting. It's funny. We have a series for clinicians and we call it The Magic is in the Visit. And it's all about how, having access to the best evidence means that you get to put down the responsibility of like having to remember the dose of the thing because you can just get it. And you actually get to sink into that strategist and that, quarterback role in someone's health rather than being like, spewing out data facts. And I hope, like, as you're saying that, I hope that physicians actually embrace that change in their role instead of being like a prescription pad gatekeeper, that they actually do get to sink into better and deeper relationships with their patients where they get to do that patient-centric decision making with them. I just think that I'm curious what that would do to physician burnout truly, because we really took some of the smartest people from a few generations and gave them one of the lousiest jobs and the least creative jobs. I'm so curious how they would feel if we allowed them to like sink into that relationship-based care.
Yeah, I mean, I think one of the biggest problems is the 15-minute visit, the 10-minute visit. It's killing patients, it's killing physicians. And I don't just mean metaphorically, yes, but also not metaphorically. And to see that system crumble or change, I don't know how to do that. If I knew how to do that, I'd have a different job doing that. But doctors like helping people. They do like doing that. You burn them out and they do tend to care less because they're suffering. But like, God, give them 45 minutes. Give them a half an hour. Like understanding somebody and understanding, and that's where the guidelines fail. Right. And why you do have to keep learning and interpret, because it's like Susie might not fit the guidelines. Right. Or she's got other goals. And quality of life matters, not just years of life lived. And guidelines are always old. By the time something gets published, it's old, right? It's like same with books, right? Like I'm putting a book out in September. There's going to be a whole 6 months of data that isn't even in there because it takes so damn long to get a book published, right? So it's like guidelines are old. The guidelines, we have international guidelines on testosterone for women. I think it's time to get it updated, and I hear it is being updated, right? So it's like when people lean on guidelines too much, that's also not great medicine, because they're not the 10 Commandments, right? They change. Nobody follows guidelines that came out in the 1970s. So therefore, guidelines are changeable, right? So we can't lay on them too heavy because they don't apply to everybody, and it should be a living document.
And it's funny, the number of studies published on hormone therapy between like 1970 and 2000 is probably the same number of studies that were published in the last 6 months. And so
I love, like, I have a group of friends and we are basically hormone experts, and I love sending them hormone studies from the 90s. It's like my love language. I'm like, there was some good shit happening. Like they were actually studying hormones a lot. Some great placebo-controlled randomized control trials, right? And it's like people would dismiss a study that was that old if it wasn't for the Iron Curtain of 2002, where all the studies freaking stopped. So it's like we actually want to look back at that because we stopped researching it for a very long time after that. And so I think we shouldn't ignore the hormone studies from the 70s, 80s, and 90s, because it taught us a lot. And then we all subsequently forgot everything.
I don't know if this is you or not, but if you're a naturopathic doctor or an integrative practitioner who prides yourself on being evidence-based, but don't have time to stay up to date with the research yourself, I have a solution for you. I'd love to invite you to explore and join the Confident Clinician, the only integrative medicine clinical decision-making tool that helps get research from PubMed into your practice with ease. We have built out exactly what you need to be the most efficient in your work, to be the best in your community, and to save you those precious hours that you're spending right now doing the research yourself. Joining with our premium membership gives you access to unlimited AI searches, gives you access to all of our previous database content, as well as our upcoming year of live delivered modules. You can check out more in the link in the show notes. I would love to see you inside of our community. We're making a huge difference in the way that practitioners practice integrative care and raising the bar for evidence-based integrative medicine. I hope you'll join us. Let's talk about testosterone for a second, because I think this is one that I've heard you talk about so well. And the analogies that you use are beautiful, right? Talking about how it is a hormone that is in all bodies, not just male bodies. It is a hormone that declines with age in all people, not just male people. And talking about that inequity and access, research, labeling, all the things that have shown that essentially we've really biased our conversation around testosterone towards men. Where is the research at right now for using testosterone in women?
Yeah. So I always start the conversation just for like the people who need to catch up, because if I'm like this crazy person you brought on who's like, testosterone's in, give it to all the people, they're like, first of all, they assume I don't know what I'm talking about. Second of all, they assume I'm trying to turn everybody into a man, right? So like there's so many assumptions because of the lack of education. So I always back up and be like, listen, this got gender biased in the 1930s when we discovered testosterone in rooster testicles and we discovered estrogen in cow ovaries, right? So like we gendered these hormones a long time ago. And then we did another bad thing. We called them sex hormones because they were found in testicles and ovaries, but they're also made in adrenals. They're actually peripheral conversion. We actually make some estrogen and testosterone in our brain, not like our ovaries do, but like these are full body hormones. And to call them sex hormones really diminishes the importance of them, because sex is extra, right? What do you need sex for after you're not getting pregnant right now? What do you need sex for? So to call it sex hormones is a big bias too. I would argue if I got my way, I would call these neurohormones, because of how, your brain is how your brain is because of your hormones for a big part. And then you change your hormones and then you're like, why do I feel not like myself? And it's like, because the feeling like yourself part, that's hormone driven, amongst other things. So all bodies make testosterone. Male bodies tend to make 10 to 20 times the amount of female bodies. You can't get estrogen without moving it through the cholesterol testosterone pathway. Right. And so, and in women who are menstruating, so their normal cycles, they have about 4 times the amount of testosterone in their body than estrogen. Because that will be the other thing. Well, if you give testosterone to women, it'll just all convert to estrogen. Really? It doesn't in your 20s, right? So that's the other big myth of like, no, the body's pretty tightly regulated and it won't just dump all your testosterone into estrogen. And they've got glamorous studies proving that fact. So we gave testosterone to women, synthetic and not synthetic. Decades ago, we treated breast cancer with it. We treated menopause with it. So like this whole thing of like testosterone's new, no, testosterone's not new. Now we gave really high doses, and those higher a dose testosterone, the more masculinizing you're going to get. But what I love about that is like, what medications do we give 10 times the dose to some people for and like see if it's safe or not? We actually have amazing safety data on testosterone in female bodies, because people who want to live as men, trans men, have been doing this for like a half a century. So we have published 50-year, we have a 30-year and a 50-year safety data on 10 times the dose of testosterone in people who willingly signed up for that level of a dose because that's how they wanted to live. No increased mortality, no increased cancer risk, no increased heart disease. So the whole like thing of like, but is it safe? I'm like, well, why don't you give 10 times the dose to people and watch them for 50 years? Like, you're not going to get better safety data on any drug. So like testosterone has amazing safety data. So I'm not sure if that answered any of your questions, but it's a fascinating topic.
It is a fascinating topic. And I love that you bring up some of the, it's interesting because I've always been so fascinated in like some of the HRT dosing strategies for people with ovaries. And we have interesting trends data on giving estrogen up to a particular level that creates a more gender affirming feeling in those patients. And then for people in menopause, we're like, oh no, you all need the same dose and we don't care about your blood levels. And yet we have this like contrasting data in the trans population where they don't actually feel themselves until we push the envelope a little bit and bring them up to a certain point. And I've always been curious if we will ever follow that thread through into people with ovaries who are treated with estrogen and whether there is this bare minimum for them to feel the most like themselves ever, which is a whole other discussion.
Yeah, no, I mean, I love that. And I think using the trans community and a lot of women, at least in America, I was part of an Atlantic article about this. I think it was in 2024. And basically like people get really good menopause care at gender affirming trans clinics because people care about quality of life. Mm-hmm. And they know that you are an individual with your own needs. And I would basically tell people like, hey, listen, I'm here. My job is to make you, I'm not going to let you do anything unsafe. Right. But like, and that's what drives me nuts when people are like, well, what dose are you on? And this, a good friend on the internet's like asking somebody what their dose of hormone therapy is like asking somebody how long it takes to clean their house. Of like, it's a different house, don't compare your cleaning levels to theirs. So I just like that because it's a very friendly way of being like, don't compare. All these bodies are differently. And, I think the heated thing is some experts get in a lot of heat for like giving some women higher transdermal doses, not understanding like everybody absorbs differently. And this is male and female data of like everybody absorbs it differently. So why aren't we checking levels at some point? Not to say there is a level that's perfect for everybody, because you're right. I don't know your receptor status. I don't know how sensitive your receptor status is. Like there's stuff we're never gonna know. So like you at a level of 40, you might feel great. Me at a level of 40, it might still feel pretty menopausal because our receptors are different.
But it's funny that we've taken the angle of like, but we're not going to try, right? And I think that's where this comes in. It's like we are so afraid as prescribers to go, you know what, maybe you do need like 2.7 milligrams transdermally. We're like, whoa, like above 2.5 is just like a no-fly zone and we're never going to go there.
Yeah, but then you give trans women oral 8 milligrams.
Right.
Right. Yeah. Like, like it's in like, and they've by and large done very fine. Mm-hmm. Right. Like we need to use everything we know in medicine to be like, are we actually being like super crazy in the way we're thinking about women and hormones? Because we're so, and this is another gender bias thing. We're so risk averse. Don't harm one woman. Therefore, harm a bunch of them by not treating them in the first place.
Mm-hmm, mm-hmm. Yeah, exactly.
Where with a guy, we're like, let's shove like plastic rods and penises to help people with bad erectile dysfunctions. Does that go poorly sometime? Hell yeah, that goes poorly sometimes. But don't take it away. You don't want to take away the treatment for men with erectile dysfunctions. Like there's risks to that. Whereas women were like, oh, one person could get hurt, so let's just let everybody suffer. Like the willingness to cause harm by not intervening is more obvious in the female population.
Well, and it's funny because we talk so much like when we're training clinicians around like the discussion around inaction, right? So your hemoglobin A1C is, approaching the level of diabetes. Inaction at this point means 5 years from now, here's what we can expect for you. And yet that conversation in hormones doesn't exist, right? We don't say inaction today will result in, and in theory, we should be talking about it with like a more emphatic tone than we are about some of the other statistics where we're very clear what happens to people if they have untreated prediabetes. And yet we're really not that clear about what happens to people if they have untreated low hormones.
I love that. And I like literally just wrote a blog post on my Substack like this week about it. Cause I'm like, do we just watch your high blood pressure? Do we just watch your high cholesterol? Do we just watch your high A1C? But they are all asymptomatic. Right. And so why with menopause and women are we like, well, let's only treat it for symptoms. Like, that makes no sense. We don't do that. Let me know when you're having a stroke, then we'll treat the stroke, instead of like, your high blood pressure doesn't have any symptoms. And that's like the 20% of women who don't have vasomotor symptoms. They're like, can I take hormones? Because they say this is only for people with symptoms. And it's like, the osteoporosis is one in two. 1 in 2 people are going to have an osteoporotic fracture. 1 in 2. That's way higher than strokes, right? And more deadly, by the way. A hip fracture is more deadly than a stroke. And there's more admissions in America for hip fractures in any given year than heart attacks and strokes combined. Right. So it's like, when people try to dismiss, like, oh yeah, but hormones and the causes of low hormones, like, that's just a small problem, right? It's like, no, it's like the problem. In Australia in 2026, so next year, the number one cause of death in Australia is Alzheimer's disease. I just gave a talk at the Sydney Opera House, and I was like, buckle up. Are you kidding? Like, next year that's happening? And I'm like, if you had a drug that decreased your risk of all neurologic disorders by 30%, it would be the top selling drug. It would have a Super Bowl ad, right? It's like, well, hormones do that, but it's not brand name. They're not. These are not brand name GLP-1s. These are not brand name diabetes meds. They're cheap, and there's not a big market force for it. And in healthcare, there's not a big market force for prevention. Right? We treat disease. We don't prevent it. Except, we're pretty good at like, wear your seatbelt, don't have a loaded gun in the house. Like, we do some like preventative stuff in primary care. But when it comes to like, if there was a drug that decreased your risk of if you had prediabetes, you already have prediabetes, and there was a drug that decreased your risk of turning into diabetes by 30%, do you think that would be part of any sort of guideline? Yes. That's estrogen. There's like randomized placebo trials in perimenopausal pre-diabetics saying go on placebo versus go on estrogen, 30% decreased risk of developing diabetes in 1 year. We have that study. That's not part of a guideline. Right? And so like, once you learn, like, the world is mad.
Yeah, and you can't unsee it, right? Like,
you can't unsee it. Like, it's so crazy. You're like, and to me, I'm like, listen, I don't have any secret sauce or a special like future ball that I'm looking in. Like, everybody is as capable of looking at the data and reading it as I am. I just happen to be obsessed with the topic, right? But it's like, I'm not holding any secrets. Like, all of this is accessible to everybody.
How do we get prescribers to be more confident, Kelly? Like, the testosterone one, I just wanted to circle back to for 1 second there, because if we look at some of the, indications for testosterone, we're talking mostly about like low sexual function, low sexual desire. And then now the narrative has shifted with estrogen too, right? Like, even the research on, decreasing the risk of dementia, we're like so close to that, causal discussion, but we're not quite there.
It's going to tip. It's going to tip. It's going to be on a random Tuesday. It's going to happen.
So how, as prescribers, do we meet like that? We don't do a disservice to the current eligible people for hormone therapy, but also not prescribe like the Wild West, right? Like, you can see things on Instagram, like people wanting, estrogen to treat their nose hairs at this point. And the prescribers are trying to do their due diligence and say, these are the indications, these are the guidelines. And then there's this mucky middle where we're like pretty darn sure that there is a lot to be gained here, but we're missing like that one key trial or that one key thing that would tip us over the edge to say we have the same certainty that we do to prescribe something like metformin.
Mm-hmm. Yeah. I think for people who don't prescribe, get comfortable with the low-hanging fruit, right? Vaginal estrogen for symptomatic women, they're going to come back and they're going to be like, oh my God, I haven't gotten a UTI since this started. I love this, right? So it's like low-hanging fruit, treat the symptomatic people. Because it's like, you and I, as thought leaders and experts, we're already so far ahead that it's like, there's so much low-hanging fruit that's being undertreated. We're causing harm by not treating the things that are like staring us in the face. The women who aren't sleeping, the women who's like, they're getting dark, their moods are changing, or they've never been depressed in their life. You know, we don't, 40% of perimenopausal women have mood changes. Some people will say 60%. Some people will say it's more than that. We're not even asking women how they're doing, right? So hot flashes, vaginal dryness, recurrent UTIs, those are like low-hanging fruit, and that's millions of women we're under treating, right? So it's like, okay, let's take care of the easy stuff first. Just fine. If you want to only treat symptomatic people, fantastic. That's 80% of that.
There's a lot of them.
Go find them, treat them. Leave the preventative health people to the people who want to do preventative health. Fine. Because I think, you know, and what you're asking is such a wonderfully insightful question, is like, here we're like, they're like, hormones are good for everything. It's like, no, they're not good for everything. And they don't work without taking care of your body in other ways. And, you know, and I think the true hormone experts are grounded in that. But like I don't know if they're like the hormone neutral or the hormone haters. They're just like, people say hormones are good for everything and everybody should be on them. And it's like, well, when you summarize a 60-second TikTok video, like, you know, there's not a lot of nuance. But by and large, these are like some of the safest, cheapest, most effective medications. Like, it's silly that it's a discussion. We give people risky medications all the time. They're not hormones. So that's the other thing, is like, give them the respect that they're due, of like, they've been around for a century. They're actually pretty cheap and accessible. The risk of them is super low. We give 10 times to the trans community. They do fine, right? Both male and female. And, so it's like, put them in don't think these are more scary than other things you do every single day.
And I love that you brought up just that like whole person care. You posted something recently on Instagram that made me so happy around alcohol, right? And that is a whole other can of worms that we will not open at this moment. But that like discussion, you know, you've got the person who's saying that, you know, hormones are bad, and then they never discuss their patient's like alcohol intake, or we don't put those two up beside each other often enough to say, well, what's the risk of this? What's the risk of that you're currently doing like on a regular basis that is so normalized? What's the consequence of not exercising, right? Like, what's the consequence of all of those other life pieces? So no, the hormones, and I always say your poor little cream doesn't stand a chance against your like the other parts of your life that also need support. But maybe if we can put doctors in that other role, right, where they do have dialogue, they do have more time, they do have an interest in helping you be a behavior change strategist, again, instead of a prescriber. Mm-hmm. Maybe, right? Like, maybe that's my pie in the sky version of healthcare, mm-hmm. where we're so jazzed to go to the doctor because we get to like learn how to take care of ourselves in such an empowered way.
Yeah. Yeah, totally. Like, you know, in me switching from an insurance-based system to a cash-based system is like the power of being heard, right? And the power of like, they heard me and they're on my team. Like, going back to the amazing course that you guys have, is like, that's the magic. That's the doctor-patient relationship. That's the healing. You know, it's like, and all of that's been taken away with the industrialization of, you know, doctors as widgets in the healthcare system. But I mean, you know, and as far as like prescribing testosterone, I know Canada, like, I hear from Canadians all the time. Canadians are like, they have no access, right? They have no access. And a big part of it is we don't have an FDA approved product.
Yeah.
Which again is bias. We've had two testosterone products go to the FDA for females. They've both been turned down. One of them was for efficacy, and one of them was 2 years after the WHI. And so that was the thought, like, it's just going to convert to estrogen, and estrogen causes cancer. And so we can't do that. You need a 5-year safety study, which would be $1 billion. So granted, we got testosterone FDA approved for men for 6 months safety data. So we've got a big bias. Just because there isn't a product doesn't mean it's not safe, doesn't mean it's not effective. It just means we've got some work to do with a product. But when you start giving women testosterone and they start coming back and telling you how they're feeling, like, no, I always joke. I'm like, nobody comes back and is like, only my libido's better. Like, nobody says that. That's not how libido works, right? And so, you know, you start hearing their stories and you're like, oh my God, I am making a difference, you know? And then you want to start learning about it more and, you know, doing it right and doing it safely. It's like, this is not hard, but listening to the women come back, that'll change your practice.
Tell me, Kelly, and my listeners, how can they get in touch with you? How can they learn more about you? You have so many ways for people to connect with your content, with your clinic, with your book. Can you just share how our listeners can find more and learn more from you?
Yeah, thank you. So Kelly Casperson MD. .com is my website, and that's got the clinic on it and the book and all of my speaking stuff. The podcast is called You Are Not Broken. The first book's called You Are Not Broken, Stop Shooting All Over Your Sex Life. Second book about menopause is going to come out September of this year. Super excited. It's just all the data for people who love the data. To give to your doctor who says there's no data, be like, here you go.
Just in time for Christmas.
Just in time for Christmas. And then let's see, what am I missing? Podcast. Oh, Instagram. Kelly Casperson MD on Instagram, because that's where I like to hang out.
Amazing. Well, thank you so much for spending time with us today and sharing your insights, wisdom, and mostly the passion, curiosity piece, I think, is what is missing in women's healthcare. And so I love to have this conversation with you. Thank you so much.
Thanks for having me.
That's it for today's episode of the Real Integrative Medicine podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.